So we've read about how some areas have lent themselves to setting up a focused factory kind of thing, and we talk about it in the book, where perhaps that kind of activity, wherein you can do a large number of surgeries. So today, for instance, you have a lot of hospitals which do knee replacements, okay? They do maybe 15, 20 in a month. And then you have hospitals that do maybe a few thousand in a month, okay? So clearly there are areas where you can do large scale activity. Do you see that kind of thing, say for instance in cardiology? Do you see that there is a possibility that a large number of elective procedures could be lined up, and do you foresee that that would help to bring down cost significantly?
Cost, yes, but for an individual patient, I don't think that's a good model. Suppose my patient develops an acute kidney shutdown after surgery. I need help at hand. The first thing that medicine teaches you is when you don't know, pick up a phone and call your colleague. Whether a patient develops a stroke, I need a neurologist. When a person needs something, I would like to have a person at hand. Knee surgery, for example, we are barking at the wrong tree. For an India country like ours, osteoarthritis, which is if you're going to project the number of knee replacement, is going to progressively increase. Why is it that it's going to increase? It's just sarcopenia. It's lack of muscle strength. If a person doesn't have adequate muscle in the thigh muscle, the load is put on the cartilage and the knee. So what India needs is a preventive model. When there's a dengue epidemic, all that it needs is to clean up the cesspool of waters around so that the mosquitoes don't breed. And you don't treat a person with terminal blood transfusion, exchange transfusion, thrombocytopenia, putting him on a ventilator, putting him on a... So, what is the social preventive medicine department doing? Why are they not celebrated? Why are they not empowered to do this? You look at several of these things, dengue, malaria, equine encephalitis. I think all of these things happen in our community. Patient is left as a vegetable at the end of the day. He goes for expensive treatment, he can't speak, he can't talk in the prime of his life. What for a simple mosquito bite? And we don't estimate the magnitude of the problem. So, I'll give you an example. There was a COVID epidemic. During a COVID epidemic, heart transplant, liver transplant came down to zero. The reason, there are no road traffic accidents. For every road traffic accident, a youngster dies on the road, we harvest the organs. But for every dead person, there are 100 people who are maimed for life, walking on crutches, who are confined to the bed. So the magnitude of what I'm trying to say is medicine is a social problem. We are looking at it in isolation. We need a whole scale, because the amount of accidents you can prevent. You will prevent traumatic injury, brain injury, you can traumatic liver injuries, you can prevent several other things downstream. So increasingly, I've been practicing medicine, I enjoy practicing medicine. But what I realize is, it's becoming more and more expensive and beyond the reach of several people. For the simple reason, it can all be prevented. 90% of them are prevented. Yes, the unfortunate few, a fall, of accident, cancer due to genetic mutation, those things are not. You need societal support for them. A vast majority of diabetes, hypertension, strokes, chronic liver disease, cirrhosis of liver, hepatic tumors, breast cancers are all led by metabolic syndromes, accelerated by some of the genetic mutations. Recurrent admissions for kidney stones, we go on putting a thing and removing the stone without realizing why the stone is formed. The hospital benefits, the system benefits, industry benefits. No one has given anything to prevent this uric acid from going up.
So I want to pause you there.
I just want to add one small thing over here. Knee replacement is 1 in 37 of patients who come. 1 in 37. We celebrate that we are doing a lot of knee replacement. We are celebrating a lot of eye surgeries, cataract surgeries. We celebrate because those are simpler stuff which can go as a factory thing. We we never celebrate. I checked out 200 patients today for BP, for those 5 number of things, BP, diabetes and all those things. If we start doing that, I think we will not have most of the problems. So once again comes back to the whole thing that we are still looking at only those where they are essentially can talk about knee replacement. 1 in 30 seconds. Poor guys don't get it. What's the big deal going to happen? He'll be sitting and doing so much.
So Guru, let me pause you there. So I'm glad you brought it down to that whole thing. Now, I believe that
diagnosing or not, but
no, we are actually making the points, they all come together. The key is that prevention is not cool. I mean, you can, for instance, a patient comes and you find his lipids are elevated, you tell the patient to do a set of things. Now, first thing is that the paradigm for treatment in chronic care has changed. In the infectious disease paradigm, the patient came to you, you prescribed something, I took that, and then 3 days or 5 days later, I was cured. Or even if you put me in an ICU, the doctor was boss. Now the doctor is telling me I got to go home and I got to take my pills on time, I got to do a bunch of things, monitor my GP regularly and all of that, and I'm not used to it. We've seen that even in large companies where the company says employee well-being is paramount, is willing to spend money to go get checkups done, etc., they don't show. And I think that it has to do with the way that healthcare is paid for. They're very comfortable paying on a fee-for-service basis. That there is a problem, I go to the doctor and the doctor is going to fix it, as opposed to I put in all the effort and therefore I gain the benefits